A very good afternoon to all of you. Today we are going to be discussing allergic eye diseases in detail in this instruction course. So as we all know, this is a very common disorder which affects about 20% of the population. And allergic eye diseases affect quality of life and they affect children, therefore they are a major cause of absence from school. They often mimic other ocular surface pathology and they may not be treated adequately or they might be treated as an infectious disease. They usually require long-term chronic therapy and therefore it is very important for us to understand them and as well as counsel our patients well so that they know that they have to be on long-term follow-up. So we will discuss both the typical and atypical presentations, complications and their management in this instruction course on allergic eye disease. So I'd like to welcome my co-instructors. We have with us Dr. AIOC2022-GP29-Updates, who is going to be talking about overview of allergic eye diseases. And we have with us Dr. Somshila Murthy, who will be talking about complications of allergic eye diseases and role of surgery in ocular allergy. So first we are going to talk about an overview. We will discuss the different kinds of ocular allergy that we have. So can I please invite Dr. AIOC2022-GP29-Updates for his talk on overview of allergic eye disease. Dr. AIOC, please.
A very good afternoon to everybody. A warm greeting from our institute. I'll be giving an overview of allergic eye diseases, followed by other views related to it by different instructors in the course. We all know that allergic eye diseases affect 30 to 50% of population, and out of that, 50% have ocular symptoms. Now, why this topic has been chosen? It's because of this. We are puzzled, we are confused, we are baffled, we are unsure, we are lost, we are unclear. And why this baffleness? This baffleness is basically in diagnosis as well as in treatment. Why in diagnosis? It's basically due to similarity in symptoms and signs. Traditionally, we have four kinds of allergic eye diseases, that is simple allergic, perennial allergic, vernal, that's what we call BKC, and AKC, that is atopic keratoconjunctivitis. The hallmark features of each one of them is ocular itching, whether it is seasonal or perennial. Now, how to differentiate them? Because there lies the baffleness. So how to differentiate them? And that's what we are trying to clear here in this forum. One, on the basis of severity of itching. Second, the onset and duration of symptoms. Third, the clinical signs. Now, if you look into the simple allergic conjunctivitis, it is always associated with mild itching. And it is seasonal in nature because the triggering agent in this is pollen, which is usually a pollen. And how does it act? It triggers the mast cell, and mast cell leads to two phenomena. One, the degranulation, which leads to the production of various mediators, and the most common of them is histamine. And the second is the phospholipase pathway, which leads to the production of prostaglandins and leukotrienes. Now this histamine, prostaglandin and leukotrienes, what it does? It basically causes vasodilatation. These are the mediators which are responsible for ocular itching. And that's why we see a classic feature in simple allergic conjunctivitis, and that is the hyperemia and ocular itching. This hyperemia is obviously because of the dilatation, that's a vasodilatation. In addition to that, we get mild papillary hyperplasia. But what about PAC, that is perennial allergic conjunctivitis? Please remember that the features are similar to that of seasonal, but the difference lies in the perenniality, means it persists throughout the years. It is not secondary to the pollen, but it is secondary to the persisting agent like animal dander or the dust mite And these are mild triggering agents, and that's why you have mild clinical features in perennial allergic conjunctivitis. So basically the difference that we have between the simple allergic conjunctivitis and perennial allergic conjunctivitis is in duration of symptoms and signs. So how to differentiate EAC with VKC? Both are perennial in nature. So how to do that? First, the onset. VKC is invariably seen in children, and it usually lasts till late teens. Regarding the geographic distribution, VKC is more common in tropical zone like in our country. And the symptoms, the ocular itching, the hallmark symptom, it's a severe in nature in VKC unlike in PAC. Now if you look into the signs, you can appreciate that in PAC you have mild papillary hyperplasia, whereas in VKC you have large cobblestone papillae. They are invariably seen the large. And it is because of the fibrocytic reaction that is seen in this VKC. In addition to that, we get the gelatinous mass of the limbus along with Horner's Tenta spots. Corneal affection is very common in VKC, unlike in PAC. And this corneal affection is basically due to release of various toxic proteins, especially from the eosinophils, and also secondary to the various mediators which are released following degranulation of the mast cells. So what happened initially, you have the SPKs. Once they confluent, they lead to the production of or the formation of this shield ulcer. Now, when the limbitis persists, what it does, it basically destroys the limbal stem cells, and that's what leads to the features suggestive of limbal stem cell deficiency. This is one of the patients at our center. You can very well appreciate there are large cobblestone papillae in VKC, and it is the grade 2 shield ulcer. Grade 1 is where you just get the erosions. Grade 2 you can get these fibrin deposit as you see here, and grade 3 I'll show you subsequently in a patient with AKC which has a plaque in it. So it is following treatment, it has occurred like this, like we gave the triamcinolone, supratarsen, as well as the AMG. Now question arises, is there any pathognomonic feature of VKC? Yes, it is perilimbal pigmentation. And there are numerous literature, there are numerous articles in the literature which suggest so. This is another literature from IE. So whenever you are confused whether it is VKC or not, just look at the perilimbal pigmentation, and if it is there, it is pathognomonic of it. Now what about AKC? AKC is also perennial in nature, like VKC. So how to differentiate them? The symptoms are also quite severe in this, especially in terms of itching, but the onset if you see AKC, it is seen in adults. There is always a history of atopy in form of atopic dermatitis or bronchial asthma, and unlike VKC, which affects primarily the upper tarsal conjunctiva, AKC, the lower tarsus, is predominantly involved. And the subepithelial fibrosis is also more common in AKC unlike in VKC, and that's what leads to fornical shortening and symblytheron formation. Now this is a patient who came to our center, a 53-years-old male, histopathologically proven atopic dermatitis. He is having the atopic dermatitis since childhood. He is also having atopy in form of bronchial asthma. He was bilaterally blind. He was brought to our OPD with his colleague, and this was the feature in the right eye. You can very well appreciate here that there is an epithelial migration which is seen here. This is suggestive of limbal stem cell deficiency. You can see a plaque here, grade 3, which is again suggestive of a shield ulcer, which is also there in AKC, but it's a grade 3 type as per Cambrian classification. This was his left eye. You can very well appreciate that there is again epithelial migration. There is inflammation, suggestive of cellularity and vascularization. You can very well see a large shield ulcer with plaque in it. So we managed it with topical steroid. Dermatologist was there who administered azathioprine and prednisolone, and And this is the picture after treatment. This is in the left eye. So at least when he was not able to walk himself, now he's able to walk himself with just the medical management without any further intervention. And he's quite happy with that. Though some of the cases are quite well managed, but there is still a challenge in terms of treatment. And why this baffleness is there in treatment? Because there is no set pattern of treatment strategy, and also there are multiple anti-allergics available in the market, so we are all confused. I think the subsequent speakers will highlight how to get rid of this baffleness. Thank you for your patience here.
Thank you, Dr. Alok, for an excellent presentation. Do we have any questions? Anything anybody would like to ask Dr. Alok?
I would like ma'am to answer this because role of blood test for the allergies normally we do not do in our practice because we do not know which is the agent, which is, it's very, very broad thing which is very difficult to do it. And I don't know what is the significance of it really.
The only test of relevance could be for detecting hypereosinophilic disease. So if the eosinophils are very high, then you know that you're dealing with a very severe form of allergy. That is also not so common in Indian population. Maybe Nikhil might have a point here.
No, one thing is, blood test is a very general term you said, so of course we all sometimes do serum IgE, but there are specific tests which can be done to determine whether the patient is allergic to any specific factor. So you have these type of tests where you challenge the lymphocytes with the allergen, the patient's cells, and then you can figure out whether to confirm the allergy you can use certain tests. More often what is done is the pinprick or the skin tests, which are where you can sort of use maybe 100 allergens or 50 common allergens in that geographical area and then do the testing. So the blood tests are there, but for each allergen there is a separate test and there will be very few maybe you could do just for confirmation, but routinely as I think the panelists have mentioned, we don't do these tests. But what is commonly done if you want to try immunotherapy is the skin prick testing to know the allergens and then make a vaccine which can be given orally or by injection.
I'd like to invite our next speaker. We are changing the order of presentations. Dr. Somshila Murthy, please, she'll be talking to us about role of surgery in allergic eye diseases and complications of ocular allergy and their management.
Very good afternoon to everyone, and thank you very much for attending this instruction course on a very tough disease. Also, I would like to thank Ikeda to involve me in this. She knows that I just love to talk about allergy. And also thank you, Ikeda, for accommodating the change in the order, and I apologize if that is changing the order for the course. So the two things Alok has beautifully set the stage, so to speak, about the disease. Just a few points which may be a little bit of repetition, but I cannot overemphasize that allergic eye disease can have a chronic, relentless course. Unfortunately, not all pediatric patients have self-limiting disease. So when the patients come to us and the parents are very distressed, so usually we tell them that, no, the child will grow out of it, and once they're older, they cross their teens, or when they're in the teens, that it's more likely to go down. But unfortunately, we have seen many pediatric patients go on to adulthood and continue to have allergy. And then that can also lead to problems such as corneal scarring, which can be vision threatening. So coming to the complications of this disease, the complications can range from as minor, just cosmetically disfiguring kind of problem. So you can have conjunctival discoloration, you can have, because of the intense eye rubbing, you can have dark pigmentation or dark circles below the eyes. And also you can have mechanical ptosis because of continuous rubbing or because of the giant papillae. So the complications can be as minor, and the parent is not happy that the child's eyes are always droopy and always red or brownish, and the child is always rubbing. But that too can be distressing for the patient, for the child, in their school, in their peer group, where they're looked upon as having different kind of eyes. So that too, it's a mental part of it is also a complication. And of course, you have the major complications that all of us are very well aware. You can have glaucoma, never due to the disease, always due to the steroids. You can have cataract for a similar reason. And you can also have corneal scar, which is due to the disease or long-standing disease. You can have infectious keratitis and ocular surface instability, including dry eye and stem cell deficiency, as Alok had pointed out. And in fact, as you can see in this list, some of them can lead to irreversible loss of vision. So the pictures I have at the bottom are patients who, the kind of patients come to tertiary care centers like ours, where you have a very severe you can see the Horner Tranter spots that Alok mentioned, and huge limbal nodules over here. And another patient with almost a small clear area of cornea and 360 degrees as panels and encroachment going closer to the visual axis. This is a pseudo-gerontoxin which we're familiar with, which has actually come so central. So when do we have to resort to surgical intervention? First, I'd like to just give you the disclaimer that surgical intervention is of course not the therapy for allergy. It's the management for the complications. So it is luckily not our first line even. It's only to handle certain situations. And medical therapy is obviously, along with supplemental therapy, is the mainstay. So surgical intervention is required in certain cases of giant papillary conjunctivitis. I think the commonest intervention we have to do sometimes is in grade 2 or 3 shield ulcers, and of course in steroid-related cataracts and steroid-induced glaucoma. When there is associated keratoconus, we do have to do certain other surgeries which may be for the keratoconus, not for the allergy. And in limbal stem cell deficiency, as well as if the patient suddenly develops a very severe microbial keratitis, we have to intervene in such patients. So this was a patient with a grade 3 shield ulcer, which has a very thick, dense plaque, and this plaque takes a very long time to subside on its own. So conservative management would not be the way to go. You have to debride this plaque. So how can we deal with giant papillary conjunctivitis? So the GPC part in VKC is very distressing. As I said earlier, it causes the ptosis, the mechanical ptosis, but it also is sort of a vehicle for permanent kind of changes on the cornea and keeps on propagating the allergy. So one way to do that and to break the cycle of continuous eye rubbing for the child is to give sort of a pulse therapy of steroid. So you can give it as a supratarsal steroid injection. So for this technique we use a 26 or a 27 gauge needle, and find the space, that is when you fold the upper lid, you can find the space just at the end of the tarsus muscle and very simply and quickly inject about 0.4 to 0.5 cc. You can't really get 1 cc in there, you may get half a cc. Here somehow it's possible. You can just slowly inject this. So for children, I always do it under general anesthesia. For adults, you can do it under topical also. I thought it would be very painful, but over the years I've been doing it, and it's not that painful. For adults, I very rarely do it. Most of the time it's in pediatric patients. Here's another case where what I was trying to show is that if you're not in the correct space, then you might sort of have just the extravasation. It doesn't go into that space that you have. So here's another site where chosen because the earlier site was not successful. It was not going in the correct space, and here you can slowly inject. If you're in the tarsus muscle, you get a lot of resistance. It won't go through. You just have to be at the fold or just below the tarsus. So that's why it's called, this is a flipped lid, so that's why it's called supratarsal injection. So it gives dramatic results. You can use a long-acting steroid, but the caveat is that you have to be very, very sure that the patient is not a steroid responder because you're going to leave it there. So I generally tend to be very timid about it, and I use methylprednisolone because its steroid response is in between dexamethasone, and which is very less, and triamcinolone, which is more sort of semi-permanent. So methylprednisolone, you have a short spike if you have steroid response, and then it gets better. You don't have to excise it. Unlike triamcinolone, if there is steroid response, you even have to excise the drug. So you can repeat this. When you give this to the child for both the eyes, typically I've seen very good response, and you can manage with other medications for the next 3 to 6 months or even longer sometimes. And then when you come back again with recurrence or back to the same stage, you can even repeat it. So that's a very, very good therapy, I feel, for the cases with giant papillary. Do you need to excise the papillary? The correct answer is no. Do not excise the papillary, but very rarely you might need to do this, and there are a few published reports. So initial report just talks about the simple excisions or doing cryoablation, which is just applying the cryo probe onto the GPC and hope for it to regress. But then it has been associated with recurrence in a large majority, and this was a study published with just 17 eyes. Can you excise and then give ciprofloxacin injection, and some people have used cyclosporine has been published, but then what do you want to achieve with excision if you're anyway giving ciprofloxacin injection? So just giving that is probably enough. Intraophthalmicin C has also been used. Some have studied 6 eyes where they've covered that area with the conjunctival autograft just to smoothen the aspect of the mechanical rubbing of the giant papillae onto the corneal surface. And some have used amniotic membrane for excision and then used amniotic membrane for a similar reason. I think logically the surgery that makes the most, makes a good amount of sense to me at least, is to either use amniotic membrane transplant or to use mucous membrane graft, and for different cases. So we have a patient with GPC, we've tried everything and it comes back again very severe, and because of the GPC there is mechanical erosion of the corneal surface leading to complication on the cornea. So these are the only few cases where I would go with excision. So coming to one such patient of ours, a 16-year-old, and the young man had GPC since age 12, and he had recurrent episodes, and one eye was worse than the other eye. And in fact, the child had just stopped going to school, and at 16, he was very much scholastically backward. He had to finish not even his secondary school that he had finished. So, and also he had gone into depression. Both eyes was cobblestone, but we chose the worst eye, which was showing this is recurrent episodes of having small shield ulcers because of this very giant cobblestone-like papillae. And every time you get the shield ulcer, it's literally very symptomatic and blinded for a short time till the ulcer would get better. So for this patient, we went ahead and decided to do surgical excision first we controlled the allergy, and then we did a gentle surgical excision and applied an amniotic membrane as well as ciprofloxacin steroid injection. This is the picture immediately within 2 weeks after the primary surgery. Looks very nice, but over the period of time, you can see that the unevenness does recur. But luckily, this particular young man has no severe recurrence like before, and he still has mild reactivation, and maybe it's burning out with age. And he went on to complete even his engineering, so this was a very successful case. But this is a very few cases that I have in hand. So I would say that surgical excision of giant papillae, in general, you don't need to do it, but when you have an indication, you can use this technique and get a decent result. So coming to the third surgery that you may have to do more frequently is for shield ulcers. And very often these are not diagnosed, and the patient goes around child not opening one eye, and you really have to think about it, suspect allergy, and because the child doesn't let you examine. When you examine, you see this plaque-like lesion. Typically, we confuse it with either infective keratitis, microbial keratitis, or viral keratitis, and the child keeps on receiving various antibiotics for months together. So all these are examples of nothing but shield ulcers, and somehow they will read about it in our textbooks, and when the patient comes to us, I've seen very experienced colleagues of ours who miss this, who probably, because they deal more with infections, so they miss this simple diagnosis. So what is the problem is that the epithelium, there's an erosion there, the mucus and other proteinaceous material has just gone on and stuck over there. It's like just made a cake over there, and so the epithelium cannot grow. And because there's this plaque-like lesion, every time the child closes the eye, there's discomfort, there's watering, there's irritation. It's like roaming around with a foreign body on your cornea. So will any medication work? No, nothing will work. You have to remove that plaque. It's like a foreign body. It has to be excised, remove that plaque, and then either on the bare base you can apply amniotic membrane, but if it's in a central visual axis, I sometimes don't do that because the amniotic membrane can integrate with the cornea and can occlude the vision in some cases. So you can do a simple excision, careful excision, and apply a bandage contact lens, and always use steroids for this patient to get them through it. So this was a patient who had shield ulcer and secondary infection, which is not infrequent because they had the ulcer going on for so long with mucus and other material which is really good source for bacteria to lodge onto. So this child had shield ulcer with corneal infiltrates. We also excised the plaque, and we debrided all these edges, and then we sent scrapings to microbiology, and luckily this patient did very well after the intervention. Of course, we did not use steroids initially, but subsequently, once the infection showed very good signs of healing, we started the patient on lower dose of steroids. It is a giant papillae which is telltale. It is not just microbial keratitis, but the patient primarily has VKC. So we published a few of our results where we looked at the management of shield ulcers, and what we saw is that perhaps it's a selection bias. So whichever were very mild, we wouldn't use amniotic membrane, and of course grade 2, grade 3 ulcers, we would use amniotic membrane. And we found that Sheila says, responding very well and amniotic membrane health test with rapid reepithelialization. We also looked at a whole cohort of patients and published this about 500 odd patients who had VKC, and we looked at the cohort, how many of them had complications. And what we saw is that fairly 11% had corneal scar, about 6% had associated keratoconus, and cataract and glaucoma were found in about 3 to 6% of our patients. And all complications, these are the complications put together, about one-third of these patients, 33% of all our patients had one or the other complication. Not all of them are serious, maybe they're just Berlin or something like that, or ptosis, but if you put all of them together. So what it means is that though we're focusing on treating the allergy, but by not treating it, our patients do land up into complications, some of which are vision threatening. So we can see that keratoconus is an extremely challenging subset. That is because it's a child will rub the eye, rubbing the eye will increase the keratoconus. And sometimes we have very severe keratoconus in these patients, or the children coming in with high drops. The second problem is that how will you assess progression? Because the surface is so irregular, you can't really rely on your pentacam because of an irregular corneal surface. From one reading to 6 months down the line, the other one, there may be automatic differences. So is it progressing or not progressing? So typically my algorithm for managing children with fairly severe, anything which is not a simple, not a mild disease, but moderate and severe disease with keratoconus, my go-through is to control the allergy very well and cross-link these children because they will progress whatever you do. I don't look at the scans and wait for any progression, but they go ahead with my goal is to cross-link for these pediatric patients. And we need aggressive, more than normal amount of medication to manage the allergy. So the surgical intervention can be cross-linking where there may be an increased incidence of haze, and of course there will be higher chances of failure because the child will keep rubbing the eye. In the case of acute eye drops, we may have to do desmetopexy. And as I mentioned earlier, that some of the surgeries are not for the allergy, but for the disease. So we do keratoconus, either DALC or sometimes full thickness for these patients, and they have a different response after the surgery, especially DALC, because the sutures get loose very fast, they get vessels superficial because of the allergy component that keeps happening. So it does affect the outcomes of our keratoconus in these patients who have VKC. So one such patient who presented with very advanced keratoconus in both eyes, and the one eye has advanced keratoconus and the fellow eye has acute eye drops which subsequently resolved with time. And this 10-year-old girl, she presented to us with acute eye drops in one eye and advanced keratoconus in the other eye. So we were wondering what we should do. Should we do a desmetopexy? It's fairly advanced, so just wait and be conservative about it. So we thought we'll do a desmetopexy, which is injecting air or any systemic pancreatic gas to take care of the problem. And this was day one after air injection. Nothing much changed after the first injection. So we decided to go ahead and do a repeat desmetopexy. This time what we did was, and if we have to do desmetopexy, I would recommend that this is the way to do it now. So first make a paracentesis, and already I've put in the air, so I've gone in the video. What I've done is I've done a venting incision, similar, not in the visually significant area of course, but similar to what we do in DSEC, and then literally massaged out the fluid that was there in the interface. And this video is kind of old because I'm going to come to another technique that we're doing now. So earlier days, this is what I would do for most of our high drops children, and carefully massage it, and then just in the interest of time. And then finally, once most of the fluid is out, do a full chamber fill, and just like DSEC, wait for 5 minutes, 10 minutes, and then decongest. You've already done a surgical PI, decongest the air a little bit so that you don't end up with a pupillary block or raised pressure. And so this child did very well postoperatively with the contact lens, got 20/50 vision, but and the fellow eye cross-linked. But very recently, just this year, finally I did the keratoconus for this child this year, and she continues to do well. So maybe if I can just talk about the compression sutures. So this is a very exciting revisit of an old technique that we've been doing now. So we know that there are compression sutures that we do along with desmetopexy. We used to do that for some patients, but I was never very happy and I never saw the logic of doing it. I thought that desmetopexy is enough, although there were some cases where desmetopexy wouldn't work. So my colleague Dr. Sunita Chaurasia, what she decided to do is in certain cases to do a different technique of compression sutures where we do a paracentesis and just fill in air into the anterior. These are patients with high drops. Fill in air into the anterior chamber, not to attach the Desceret's membrane, but just to keep the AC form. And based on the air which you roll into the eye and see where the does not break, you decide on your compression sutures. So the background is a partial air-fill in anterior chamber. And it was literally like magic. So the first case I did when she guided me how to do it, it was a child with similar disease. I could see reduction in the corneal edema an hour after surgery, and within 1 week the edema had completely subsided, the decimals had attached itself. It may not work in all cases, but definitely the rapidity of resolution is faster than what we were getting with desmetopexy. So we have published this initial 3 cases just recently. It had to go through a lot of reviewers. They were not convinced about our technique, and you really have to read this article to get convinced about, but till you do a case, you won't understand how well it works. So I'll share this some other time, but I'll just ask you to go through this from literature, and so we are now enrolling the patient into a study and trying to look at this, and maybe later compare it with simple desmetopexy. So my last couple of slides, should I wind up?
We have a lot of time, ma'am, because we have to talk, so we have time. Please go ahead.
Yeah, I'm sort of standing in for Dr. Sangwan also. So ocular surface and stem cell treatment is something that we have developed. And we know that chronic limbal inflammation which happens in patients with chronic UPC, all that nodules that we see at the limbus, what they're doing is that they're knocking down the limbal stem cells. They're creating a very unhealthy niche because limbus is where the stem cells reside. And eventually the stem cells will die, and about 30% patients in the series that they had studied, Josh also who didn't make it studied, showed that patients with allergy would have stem cell disease, either partial or complete or whatever. So very early on when I first joined and I worked with Dr. Sangwan, we published our results in 2005, where he had, in many of his cases of limbal stem cell deficiency where he had used cultivated stem cell transplant when he had started that, he had used it in 2 patients of VKC also, and he had seen remarkable results. Of course, it was a bilateral disease, so he had to take cultivated cells from the donor, from one of the parents. And based on that, subsequently they went on to do even select for patients with stem cell disease following VKC. And recently also we reported a case of where we have done something different. Patient with LSCD, that is limbal stem cell deficiency, which was the end result of a bad allergy. So when we did the quadriplasty, we did a donut amniotic membrane for these patients. So there are a lot of add-ons that you can do to rescue the eye once they land up into stem cell deficiency, and looks like it seems to be the same way in which the limbal stem cells are getting knocked down, because the therapeutic part of it resembles what we use for other patients of limbal stem cell deficiency, proving our point that there is stem cell deficiency that can occur due to the chronic disease in VKC. So glaucoma is no different. It is steroid-induced glaucoma. There is really nothing except that it's a pediatric patient has allergy, and then the patient has glaucoma. So this is of course obviously due to increased usage of potent steroids. So we have to be very, very careful and limit our use of potent steroids. Most of the time it's not the ophthalmologist, it's usually the family or the parents, because they wouldn't know otherwise, and the child has been using the drug for years and years and comes to us with either glaucoma or with a cataract. And it's not extremely difficult to manage the glaucoma, but it's extremely difficult to manage the allergy because the allergy was steroid dependent. That's why they were using the drug. It's not that they just liked it, but the minute they would stop steroids, they get a bad allergy, and they tried everything else already. So what do you do for them? So we put them on oral medication. We even put them on oral steroids, because the logic is that although topical steroids are the culprit for the glaucoma, oral steroids do not raise the pressure as much, or maybe not actually. So we of course monitor the pressure, and then we switch them on to other agents, not steroids, but you can use cyclosporine, or you can use methotrexate or mycophenolate, because we use them anyway for our other patients with chronic diseases like uveitis and so on. So we have a rheumatologist, or you can use it even with a very good physician, with the help of very good physician or pediatrician. So glaucoma filtration surgery, the results my colleague Sirisha published recently, and so the results are good, the outcome was good, but the problem was, and the tragedy was, that by the time 1/3 of the patients were already in advanced cup-disc ratio in these patients. They were literally, by definition of blindness, they were bilaterally blind literally, and 1/3 of patients that she had, who had glaucoma after VKC, they needed surgery. So once they get glaucoma, it seems that the rapidity with which it progresses is very bad. And in cataract, Again, not really very different. The outcomes are reasonably good with PCO, as you can expect in young patients. The only thing that's challenging is the IOL power calculation because the ocular surface is very poor. So I just want to show you one example where the IOL power was calculated and the power was as -2, whereas the standard. So what our technicians tend to do is that whenever they have an ocular surface which is irregular, the MAG is irregular, they just use a standard proof. For them, everybody in the world, every human being in the planet has 44 diopters in standard proof, so they just put that and give the IOL power. So the standard proof, if you are just in a busy OR list, just look at standard power and put 14 diopters, you have been way off target because in this particular case that I had, the IOL power is actually -2, so we use the oculizer or we use a central part to get the Myers from the central portion, and then so remember that the IOL power calculations can be erroneous because of the ocular surface. That's all you need to remember, and it becomes even worse if it's a keratoconus patient, which it was in this case. So this is just to show one of the same patient where the IOL power is erroneous and has good visual outcome in both times, 2060 and 2020. But of course the allergy is still active, so that part doesn't go away. And patient has to be told because they think that they're investing money, allergy has to go away. So if you tell them they're two separate things, this is a cataract that you're handling and the vision will get good, but the allergy has to be controlled in other ways medically. Thank you very much. Thank you once again.
Thank you, Dr. Sobshida, for an excellent talk. I would like to add in here my experience with the compression sutures. So I have done 3 cases so far with a patient with hydrops and descemetic Esc combined with compression sutures. And it's remarkable how well they start feeling better. So one patient I had operated in the morning and I saw her in the evening itself. She said that I actually feel that I can see better. I think the way that it works is wherever there is a descent stair, we make the sutures, we place the sutures perpendicular to that area of the descent stair. And probably it's like having a corneal tear, how we place sutures perpendicular to that. So the cornea is most edematous in that area, and just applying compression sutures the right way perpendicular to the descent stair probably helps in releasing that fluid and closing up that descent stair earlier than it probably would if we had done only a descemetic Esc. So this is a new technique I think that works beautifully well. Any questions that we have, or would Dr. Somshida like to?
The technique is not new though. It's a very old technique. It's just that probably we were not using it.
We were not using it. So it's relatively new for us. We've been using it for some time now. And again, what Dr. Somshila was talking about, excising these giant papillae, which is not really recommended for most of our patients because the pathology here is mostly that there is ocular surface inflammation, which is the underlying factor for allergic eye diseases in general. So it is more of the associated inflammation, and very few cases actually have a mechanical erosion. So that's the reason why we need to control the allergy more than concentrating on the papillae and removing them, because we will definitely have a recurrence if the allergy per se is not controlled by medical therapy. Any other questions, anything you would like to discuss? Do the audience have any questions? We have some time so we can have a little bit of discussion. So then I would like to invite our next speaker, Dr. Nikhil Gokhale. He will be talking about the medical management, and maybe at the end of medical management we can have a discussion about management of allergic eye disease a little bit more in detail. Dr. Nikhil, please.
Thank you. So basically when we think of treating a child with or a patient with allergy, I think that as we saw in the first talk, it depends on what is the type of allergy and what is the severity of this allergic eye disease, so that we can accordingly manage our patients better. If you look at these flowcharts, you might find there are several ways you can target the allergy. However, in private practice or in practice, sometimes we resort only to steroids, and I think that is something that all we need to rethink how we should treat them more optimally. The problem is that if you over-treat your patient and you have a nice white eye, no symptoms, the patient is pretty comfortable, you might have side effects of treatment, and the patient might lose vision with glaucoma or cataract. On the other hand, if you under-treat your patient, you will have inflammation which will persist, and you will have tissue damage, and this can itself cause limbal deficiency and corneal scarring. So either way, it's a difficult challenge, and we have to balance our treatment strategy so that we are able to neither lose vision due to any of these factors and maintain the typically what happens in most practices is that we tend to give a course of steroids in a paper. The child and the parents are pretty happy, and then once the steroids are stopped, there is again a recurrence of disease, because as we understand, we are not looking at curing the disease by giving any of these immunosuppressive drops. The child comes back to you, you again repeat it. This can happen for a few times, and then the child will go to the next neighboring doctor, and again such things might continue. I think what we need to do as a doctor is to understand what is the course of disease. We need to look at what were the past treatment and response, judge the periodicity and severity of disease, and once you have answers to some of these, try to counsel the anxious patient, because most of them are extremely anxious. It's very important to set up what expectations are there from your treatment, so that we can look at long-term management of inflammation in a safe manner, and for this we need to use a step-ladder approach. So this is just a little bit about, I would spend a fair amount of time trying to understand what has happened in the past, because I would see many of these patients who have had months or years of treatment before landing up in my clinic. So typically if you have a patient who has used surface steroids and had a complete response to the steroids, however the disease recurs within a few days of stopping the steroid, I know probably it's a little bit of a moderate form of VKC, maybe a chronic form, whereas if the patient responded well and there was no recurrence for a few months, maybe it's an intermittent variant where you give a mild steroid, the child is okay, a few months down the line there is a recurrence of the inflammation. On the other hand, if there has been absolutely poor response to a surface steroid alone, you know you're dealing with something which is fairly severe inflammation, and if there is a partial response, again this could be a moderate form of disease. On the other hand, if the child has used potent steroid, has had a good response to a potent steroid, and the disease comes up as soon as you stop the potent steroid, you again know you're looking at a fairly severe form of disease. However, again there will be some who may show a response for a few months and then come back. So these could be some of the intermittent varieties. So just by looking at the history and all the old papers, sometimes you have a clue as to what you are going to treat in this given child. And basically I think what we need to follow is try to use a system whereby we can document all the signs at every visit, try to grade the severity of disease, and based on that formulate what will work best for that given patient. So you could have a child or a patient who has mild disease, or maybe even the seasonal allergies will come here where you don't have any corneal involvement, it's just some amount of symptoms of itching along with conjunctival pathology. Whereas you have more severe forms of allergy where you have corneal involvement, cobblestones, and in the most severe forms you could have shield ulcers, corneal scarring, and limbal failure. Also you will have a subset of patients who have had past allergy who now have a burnt out ocular surface disease and may not truly have allergy, but they have surface problems more because of past inflammation, which might need to be tackled little differently, like other than an acute inflammatory process. So our treatment algorithm has to be based on what we are looking at. Basically the concept is that if it's an intermittent form of allergy, you could safely use a mild steroid or a steroid maybe once in a few months and you can get away with it. But whenever you come across a situation where there is a chronic disease, a 365-day disease, you need to look at steroid sparing agents, and you can use cyclosporine, which can be formulated at higher concentrations than the commercial cyclosporine. And now more luckily we have tacrolimus, so you may not need to make all these drops, and you can try and control the disease. Of course, the very severe forms of disease will require steroids, potent steroids, and higher strengths of steroid sparing agents. And the extreme cases might need even systemic treatment and surgical interventions. When you're looking at something which looks like a severe form of allergy, which is not responding to your routine medications, you need a pretty high dose of medications. Always consider, if possible, to do an allergy testing and consider immunotherapy if you have access to a good person who can manage these children along with your medical treatment. So basically, as you can see here, what you can do is that if there is just conjunctival involvement, there's no need to give steroids. You can usually manage them just with mast cell stabilizers, dual-acting drugs, and so on. If you have intermittent disease, you can try surface steroids in short pulses. If you have chronic disease, try to use steroid-sparing therapy along with maybe a very low maintenance dose of a surface-acting steroid. Whereas in severe and blinding forms of disease, you'll have to be more aggressive with steroids topically and sometimes systemically as well. So the objective of recording signs and symptoms at each visit is that you can follow a step-ladder pattern of therapy, because we know that the allergy can fluctuate either because of the natural course of the disease, we know it could be seasonal, and also because of effect of the medical treatment. So as the allergy goes severe, go up the ladder. As things get better, you can start going down the ladder and try to balance it. So if you use this type of treatment, you can probably avoid over or under medication and try to treat them optimally. So steroids do have a role. They are very useful when there is an acute episode, when there is a very severe form of VKC, and we usually use a pulsed approach of steroids rather than using continuously a very high dose for a long period of time. There are also other patients who may be maintained with a steroid-sparing therapy but have a little bit of a persistent inflammation where you might use a low-dose maintenance topical steroid. In general, it's better to use a soft steroid if it works rather than directly using a potent steroid. It's good to maintain and monitor usage, and it's easier said than done, but it's very difficult to monitor intraocular pressure in children because they may not cooperate, they may be very photophobic, so you need to be careful, especially if they're going to use it for a longer period of time. And the steroid response is much higher in children than in adults, and this has been shown. And also, of course, we need to be remembering that you can end up in a cataract. So if you have a very young child who has got severe and chronic form of allergy, I think we need to be very careful with steroid usage, especially if there is a possibility that the child may disappear and self-medicate or abuse these drops. Cyclosporine can be reconstituted from the injectable preparation, or we also have orosporin, which can be titrated to the desired concentration that we require. And cyclosporine has been found to be fairly stable in artificial tears. Basically, we use it as a steroid-sparing agent. Again, this can be continued on a long-term basis in patients who have chronic allergy for a very long period of time, and up to 7 years of continuous usage has been reported in the literature. And in addition to its anti-inflammatory property, it's also anti-fibroblastic. So you see a lot of hypertrophic changes in VKC, which may be sort of suppressed by using these drops. For many of us, or for many patients who cannot access coming to a clinic repeatedly to get these drops formulated, tacrolimus is a great advantage, and this can now be prescribed because they are readily available in the market. And the only issue is, of course, there may be a little bit tolerance is in one of the problems that you might see, but definitely, again, this can be used on a long-term basis and probably a good steroid-sparing agent which is now available to us. Sometimes you come across these type of children where you feel as if you are losing the battle and the child might lose vision. In some of these situations, you might have to use a systemic agent for long-term management. However, this should always be managed with an immunologist or a rheumatologist. The doses we use are much lower than organ transplant dose, just to say that that would be relatively more safer. And so basically, if we treat our patients well, it's very, very rare that you'll require all these systemic management or systemic medication. However, when you have a situation, for example, you have an emergency situation of a poorly managed VKC, as you can see at 0.3, you might have to use steroids. For example, I would give you, let's say a patient has come with a shield ulcer, we've given a supratarsal steroid, we have debrided, still not healing, you might give a little bit of oral steroid. Or then you have a patient with extremely severe disease requiring too much of topical steroid, not getting controlled, getting recurrent shield ulcers, limbal deficiency, you might use a systemic cyclosporine. Similarly, if you have done reconstructive surgery in some of these children or these patients, you might have to use systemic medication. Otherwise, the indications are fairly rare. If you treat them and keep monitoring, hopefully you don't require such strong medication. So there is another subset of patients who have VQC adult onset. So we know VQC in childhood continues into adulthood, but if you have a new onset of VQC in an adult, you need to rule out HIV infection, because here the treatment is not immunosuppression, but to use antiretroviral therapy, and this is something that we have to keep in mind. Shield ulcer, Dr. Somashila has discussed. Depending on the grade of shield ulcer, what you need to do. So this is just the supportive therapy which will be very helpful, especially in milder forms or as an add-on in severe allergies, where you might use the dual-acting agents, which are quick in action, and they have good long-term effects, so you don't need to use them very frequently. And similarly, you could use in certain situations oral antihistaminics when there are a lot of systemic allergy also going on along with it. And oral leukotriene inhibitors have limited benefits. Nasal allergy, if associated, usually nasal steroid sprays definitely help to control even the ocular allergy to some extent. Cold compresses are extremely important to stop the child's hand going onto the eye and rubbing and then getting into astigmatism and other problems. Lubricants, preservative-free, very helpful to flush allergens from the ocular surface. They must use hygiene, avoidance measures and protective glasses. These are something that we all need to use in all patients of allergy. And as I said, immunotherapy could be tried in very severe forms of allergy. It's the only treatment that can change the natural course of allergic eye disease. And some of these complications require surgery, which Dr. Somashila has discussed. And these are some of the avoidance measures that one can try. And it's an endless list, and you could keep doing it. May not see much effect, but I think they're worth trying. So I thank all of you for your patient hearing. And if there are any questions, definitely address it here. Thank you.
Thank you, Dr. Nikhil, for that wonderful talk. So just to discuss a little bit more clinically, we've learned a lot of, you've told us in detail about all the drugs that we use. So if typically a young patient walks into your clinic with, say, mild to moderate amount of VKC with history of recurrences, what is your typical prescription? What would that look like?
So if I have a patient who has chronic VKC walking into my clinic, then normally if they're already on steroids, I try to taper the steroids off. I usually start cyclosporine if the child can follow up, and if not, tacrolimus along with some lubricant and antihistaminic or mast cell stabilizer. And then I monitor these children over the next few weeks and months. If possible, I try to wean off the steroids totally and try to maintain them on steroid sparing agents like that. And if the history, as I said, is of a very intermittent or once in 6 months or 3 months or a mild allergy, then I would just use steroids on and off whenever required.
So in my experience, tacrolimus, again, I would agree with you, works wonderfully in allergy. It is more potent in ocular allergic diseases, especially VKC, than cyclosporine eye drops. And keeping them on tacrolimus eye ointment, initially I like to give it 2 times a day. And then just once at night, continued for a long, either 0.1 or 0.03%, both of those strengths work really well, and patients experience, immense relief after this treatment. The only thing that we need to remember is that the first couple of days might be a little difficult for the patient. They might feel that it is sort of an irritating, ointment to be instilled into the eye. So a few practical points are that when we are prescribing tacrolimus eye ointment, we need to instruct the patient that it has to be used in a very small amount, as small as probably a rice grain inside the eye. So, and this can be given for a very long time. It helps in reducing the dosage of steroids that we need to give these patients very frequently.
Yeah, I have a question. Am I audible? Yeah. To both the panelists, and just now Ikeda was talking about it. So what is the longest duration you have given tacrolimus in your practices so far?
Yeah, basically if you fall upon literature, like what I was showing you, even literature data is there to modulatory than totally a suppressant. And the only thing about it is that it burns or whatever, that is the issue. Otherwise, they are fairly safe for long-term usage. Originally, there were some fears that you could trigger neoplasia. There were some skin preparations which were being tried for eye, like the pimecrolimus, the Novartis, and then it was abandoned because there were some skin reports that it might trigger some sort of neoplasia, but at least ophthalmic, I don't think there are any major or any such data as of now.
Yeah, I would agree with you. I think even I use it almost indefinitely, especially in patients who have a lot of references, or when we have VKC-associated keratoconus. For those patients, we really need to maintain them on long-term tacrolimus. I think more important is, more than the side effects, is the counseling, because the patients would tend to come back and ask you, how long am I supposed to keep using this for? So what I typically tell them, it's like having hypertension or diabetes. If you take drugs for that, it's kind of similar, and that seems to convince them that we need to use them for long term.
Sure. Thank you.
Yes, please.
Yeah, so the first question was, why do you want to see them, follow them up? So basically, as I said, that if you are not going to use any steroid, we know the calcineurin inhibitors are not as potent as the steroid. So I want to ensure that at least the corneal inflammation is settled down, because I don't want to have persistent limbal inflammation or persistent surface staining to persist once I am treating my child. So I keep monitoring the surface staining as well as the amount of limbal inflammation. If I feel that it is not adequately controlled, I would either change the concentration of the cyclosporine or add tacrolimus, or sometimes add a loteprednol drop once a day and then keep observing. So we need to titrate till we come to a good control. So for that I need to see the patient at least initially. Once we have gone under control, then probably we can pull on, and then I would try to reduce the dose and again keep titrating it. Some children, once they are okay, I might see them at 3 months or every 3 months or things like that, but it's a long-term treatment and we don't want to, as I said, over or under medicate. About cobblestones, typically, as you said, my indication of giving a supratarsal steroid is when I have a patient who comes with a shield ulcer. So many of these children have plaques which need debridement. So at that point of time, I have to give them some general anesthesia and debride it. So at that time, I use the supratarsal steroid. Frankly, for cobblestones, I very rarely have required oral steroids. I have used oral steroids in a couple of instances when I did a shield ulcer, or the ulcer itself is not healing despite whatever has been done. I have had patients who have already an AMG, who have supratarsal steroid, then they come to my clinic and still it does not seem to be healing. I have used oral steroid in some of these very severe cases, but otherwise for cobblestones, again, oral steroid we can give, but it is maybe just for overcoming a crisis or emergency situation. In the long term, it's not going to help, because we have to look at alternative strategies, because this disease is going to keep going on and on. So when there is a crisis, I would use a strong agent, and then once we are through the crisis, maybe switch back to maintenance sort of treatment. Oral MSA? Yeah, so cyclosporine is expensive. That is one major problem which is there. So I have very few, 1 or 2 patients where we use methotrexate because they were not affording and cyclosporine was not possible. But otherwise, I don't have a very big volume of maybe Somashila not here, maybe at LVP and all they have a very high volume practice. Maybe they might have more cases, but you can use. I have used methotrexate in consultation with a rheumatologist.
So cyclosporine, oral cyclosporine actually works really well for some of these kids who have very severe forms of VKC. and we can safely continue it for quite some time. There are no significant side effects in the pediatric age group, but like Dr. Nikhil said, it's better to have a rheumatologist on board. Sometimes if they have associated, atopic conditions or dermatitis, a lot of dermatologists also, you can talk to them and discuss with them and are comfortable starting oral cyclosporine. So that would be the drug of choice, but we have to monitor the side effects. If needed, methotrexate can be started for these patients, but the drug of choice for control of inflammation would remain cyclosporine. Sometimes we do come across these cases with severe VTC who have keratoconus, who have limbal stem cell deficiency, and that's when oral medications would come into place. Even oral steroids for a low dose may be continued for a long time. Of course, they need monitoring. But for severe cases, oral therapy does work and might need to be started for a few of our patients that we see in our practice.
So typically you get these, end-stage glaucoma. Somebody is coming with a PCIL, 0.9 cup, bilateral, and as soon as we stop steroid, they're into a lot of inflammation, limbus, and all those things. So we really have no option there. Even the topical cyclosporine tacrolimus don't seem to be helping. So either, you're going to lose the eye, or so in those situations there is virtually no option, And the immunotherapy and the other things I said take at least 3 to 5 years for them to probably, work well. So these situations are rare in practice, that is what I said. So they're not very common, and we need to be judicious in using it. I mean, if we can somehow get it under control with local therapy, we don't need all these things.
Can I add to that, sir?
So topical eye typically in my practice use 0.5%, and in very severe cases 1%. So because the 2% is not well tolerated, as you said, with oil-based preparations, initially I followed the books and tried to prepare it in different olive oil and other oils, and it was absolutely not tolerated by the patients. So with lubricant formulation, they are fairly well tolerated. And there is literature data. In fact, I have done they do the serum cyclosporine level in the laboratory for patients on oral cyclosporine or systemic cyclosporine. So I have actually done the cyclosporine concentration in the lubricant after 1 month of keeping the bottle or using the bottle to check whether it is maintained or not. Because as you rightly said, it is not going to mix up well. So we have to shake the bottle before we use it. So it's like some sort of a suspension. So whether the concentration drops over a period of few weeks, what happens? I actually sent it to the lab and told them I want to check what is the cyclosporine concentration, and it seems to be maintained.
We have our own experience at our center, sir. I would like to share with you. Like for VKC, we know that VKC, it's very rare to get a very severe disease in VKC. Whenever you get a very severe disease, I think it works quite well with oral steroid. Then regarding AKC, again it's a very rare disease, so in our center we always take consultation with the dermatologist, and they invariably start azathioprine. And I have found azathioprine 15 mg. It's quite safe also, and it works quite well. Because if you have seen my presentation, I have shown he was treated with low-dose steroid, oral steroid, along with azathioprine 50 mg for a longer duration, around 9 months. So he has recovered quite well. Cyclosporine, of course, is one drug, but azathioprine also is a drug which we can opt for because it's more safer than cyclosporine.
In my practice, I see a lot of patients who are referred after many years of therapy with lots of complications. So I might see a little bigger subset of refractory cases, but otherwise in your routine practice, you may not have, you'll have most of your patients will be managed well with local therapy alone. So our next speaker is Dr. Ikeda, and she's going to talk to us on various masquerades about allergic eye disease, and look forward to her talk.
Can we please have this laptop connected? So I am going to go back to the basics now. We have talked about systemic therapy. We have talked about the complex cases and the complications associated with VKC and allergic eye disease and the surgical management of eye disease. Now, when usually we have a severe case, we don't, the diagnosis is not usually an issue because if they have cobblestone papillae or they have giant papillae and they've been treated for VKC for time, usually diagnosis is not in question, it just becomes about therapy. But most often what we see in our clinic are mild to maybe moderate disease, which can be a little confusing, and I'm just going to talk about very basic, how to differentiate different kinds of diseases and what are the conditions that can mimic ocular allergy. So allergic conjunctivitis can be often overdiagnosed because there are a variety of conditions that present with similar symptoms of congestion, phimosis, and watering. The predominant symptom that we need to remember here is itching. More than grittiness, more than watering, what they come to us is with itching. So the conditions that I'm going to talk about are the conjunctivitis subgroup. They can be confusing and they might look like ocular allergy and vice versa. Then we have the dry eye disease. Flick-tender conjunctivitis is another important differential because that also usually presents in younger population. And then we have episcleritis and a rare differential of ocular cicatricial pemphigoid or mucous membrane pemphigoid, which can be a differential diagnosis for atopic keratoconjunctivitis. So let's start with viral conjunctivitis. It's going to be a very clinical presentation on how to differentiate these disorders in the clinic. First and foremost, these patients usually will complain to us with irritation, foreign body sensation, watering, more than itching. So the predominant symptom usually here would not be itching. And if we ask these patients, they'll typically tell us that there's stickiness of lids in the morning. When they wake up in the morning, there's some amount of crusting. There might be associated lid edema when we examine them. And unlike allergic conjunctivitis, it usually first involves one eye and then spreads to another, whereas usually in allergic eye disease, both the eyes are involved in the same time. When we look at the lower fornix, we might find discharge, which is again a little unusual in allergic diseases, and there are more of follicles than papillary. There can be associated signs which can help us in diagnosis. They might have membranes and pseudomembranes, so it would be worthwhile to avert the upper lid and take a look and see whether they have any membranes and pseudomembranes associated. They might have subepithelial infiltrates, which are very, very typical of adenoviral conjunctivitis, and preauricular lymph node involvement along with upper respiratory tract symptoms, and fever would also indicate towards a viral disease. Bacterial conjunctivitis is fairly easy to diagnose and is very, very rarely confused with allergic eye disease because they have copious amounts of discharge and membranes. Another important condition is that of toxic conjunctivitis. It could be a drug toxicity because of the multiple drops that the patient has been using, or the preservatives in the drops, or even plant extract like calotropis. These patients usually don't have any discharge in the lower fornix, but they have this congestion, which is more common in the lower fornix and the lower tarsal conjunctiva, whereas patients with VKC would have congestion more in the superior fornix or the superior tarsal conjunctiva. And all the signs would be inferior. They might have inferior SPKs and inferior corneal edema as well. Let's talk about now the dry eye group. So more commonly what we see is uveitis and blepharitis. So it is important when a patient comes to us with itching, watering, grittiness, we need to take a look at the lid margins, and a lot of these patients, younger patients, could also have blepharitis. So that is something which is an important differential for allergic eye disease, and they might present to us more again with complaints of irritation, burning on watering rather than itching. So looking at the meibomian glands, which also help, and they might again have associated signs like inferior SPKs or marginal keratitis, typically seen at the area where the lid margin touches the cornea. So these again would point towards more of a dry eye group rather than allergic disease. So I would just like to share an interesting case here of this 3-year-old boy who had been treated as ocular allergy for quite some time, for about 4 weeks or so, and he kept complaining of itching and watering and redness. So he had gone to a couple of ophthalmologists and he was treated again for allergy without any relief in his symptoms. So when I examined him, we need to take a closer look at the lid margin, and he actually had pediculosis. So Dermatitis and pediculosis again becomes an important differential. So we actually took him to the OR because he had a lot of pediculosis. We removed all of these, and this was followed up by tea tree oil treatment. So this is something that we need to keep in mind. A dry eye, to differentiate dry eye from ocular allergy, is that usually they present in older age group. The age group might be different, although we do have adult onset VKC. And they again present more with grittiness, dryness, burning sensation associated with intermittent blurring of vision. So So most important to differentiate dry eye would be to look at tear film breakup time and the ocular surface staining, the pattern of the staining. So SPKs would be more common in the indal palpebral area rather than the superior cornea, because in VKC that's what we see. And associated filaments are also unusual to find in patients with VKC. We could, if we have findings in the superior conjunctiva, it could be looking at superior limbic keratoconjunctivitis. So this is a 67-year-old female patient who presented to us with symptoms of irritation, dryness, and grittiness. So what happens here is that there is bilateral inflammation of the superior conjunctiva, and there is redundancy and thickening of the superior conjunctiva as well. There can be associated papillary reaction, and filaments are usually again seen superiorly here. So this is something you need to keep in mind, that we might be looking at a case of superior keratoconjunctivitis, but these are usually older patients and they have associated thyroid abnormalities. A rare differential is that of floppy eyelid syndrome. This is typically seen in male obese patients who have a tendency towards sleeping face down, and they develop these SPKs and reaction only in that area on the side which they are sleeping. So if they're sleeping on one side, you'll have it more in that eye than the other eye. They have very, very lax upper eyelid tarsus, which is easily everted. So when they're sleeping, the tarsus gets everted, and they might develop SPKs because of the exposure that they have. Now, flictengular keratoconjunctivitis is another important differential, because this usually presents in the younger age group, and it is usually unilateral, which would help us in differentiating from allergic disease. And if we stain, we'll typically find an isolated nodule on the top of the flicten. So that would help us in differentiating this disease. Episcleritis usually presents with mild discomfort. Patients very rarely complain of itching. They would just come with redness and mild discomfort. It's sort of a painless congestion, and there are no associated papillae and no associated follicles. And the last differential would be the ocular cicatricial pemphigoid, which is seen more commonly in elderly individuals, and it's a bilaterally progressive disease. They have severe dry eye, they have cicatrization and symblepharon, cornical foreshortening. So it could be an important differential for atopic keratoconjunctivitis, because if you have a severe AKC, these findings might be present in AKC as well. So this is something that you need to keep in mind, and these patients would require systemic immunomodulatory therapy. So to conclude, how do we narrow the differential diagnosis? First and foremost, if it is not itching, it is probably not allergy. So if you have itching, we are looking at ocular allergy. If you have more of a burning and ocular irritation, we are probably dealing with dry eye. Lots of times, dry eye and ocular allergy are confused in a way that one could be treated as the other. So this is one very simple symptomatology-based differential. And if we have any kind of discharge, whether it's mucoid discharge or just pseudomucinous discharge, then we could be looking at conjunctivitis. So this is a decision tree. First of all, if there is ocular itching and redness, yes, then we are looking at allergy. If no, then we need to consider an alternate diagnosis, and maybe it is a mimicker for ocular allergy. Next thing we need to do after we've asked the symptomatology is to look at the lid margin. So when we look at the lid margin, we need to concentrate whether this patient has pneumonitis or blepharitis. If yes, then treat accordingly. Does the patient have any skin manifestations? So what we can ask these patients, sometimes because of this allergy, they might have associated asthma, or they might have skin findings. So they might have allergic rhinitis. So we need to ask them symptoms of allergic rhinitis, whether they have frequent sneezing, whether they have any skin lesions, whether they have any asthma. So all of these supporting findings would again suggest that we are looking at an allergic eye disease. Is the patient a contact lens user? If the patient is a contact lens user, we might be looking at GPC, and that is one history which should not be missed. So that could just be contact lens induced GPC that we are looking at. Skin manifestations are more common in patients with AKC or atopic keratoconjunctivitis. Again, rhinitis, asthma, like I said, would be important corroborative finding for us to strengthen our diagnosis of ocular allergy. VKC, as discussed in detail, can present with all of these symptoms, so that will help in diagnosing VKC. And the last but not the least, you might have irritative conjunctivitis just because of the environment pollutants, which is quite common in Delhi. People typically tell us that we have shifted from a a town from a smaller town to Delhi recently, and we've had a lot of itching and a lot of irritation. So this is just probably the environmental pollution and smoke which is irritating the eye. So that will be the last differentiate. So that is the end of my talk. Thank you so much for your kind attention. And if you have any questions, we have a couple of minutes. I think we can discuss, or if the panelists would like to add anything. Yes, ma'am, please. Yes. So you said you're giving periocular tacrolimus. Yeah, so that also works because it does get absorbed to a certain extent, and so you just ask them to apply it on the eyelid. So I think it does get absorbed, but probably not as potent as it would be when you're asking them to instill inside the eye. And also sometimes they have sort of, I've seen a few patients where if it is applied on the lid margin, it does not happen with all patients, but they develop a little bit of skin excoriation and redness in that area. So that's not my preferred, choice of giving it as, but maybe the other panelists would like to share whether periocular would be a good.
Yeah, with tacrolimus, there are some pharmaceutical preparations which are much better tolerated than the other. So you need to try them out and see, which your patients or, which ones are better. I don't want to put any commercial names here across on this, but there is a lot of variation in the tolerability, that is one. The second thing, as Dr. Ikeda rightly said, was, that generally when we tell them to put ointment, they just put a 2 centimeter strip or whatever, strip of ointment into the eye. So we just tell them to put less than a drop. Some of these tacrolimus are just like a gel sort of thing. So you put a very tiny drop which is just enough to spread into the eye. So then they probably, and tell all patients that it's an irritant molecule, but it is a safer molecule than a steroid, so we have to try it and persist with it. So over a period of time, most patients will start accepting it. If you don't tell them, then they will call you within 12 hours and tell you, this medicine is causing too much of problem. So once you have warned them in advance, probably they might be able to better accept the situation. But of course, some patients may not tolerate. It also depends on the activity of disease. For example, if you have a very inflamed eye and at that time you want to use a molecule which is very irritant, it will trouble them more. Once the inflammation is relatively controlled, maybe with a steroid or some milder surface steroid, once the eye is a little quieter, maybe they might tolerate at that point a little better, because the irritation of the or the inflammation itself has settled, so the tolerance may be better. So you have to keep trying, because transdermal you can use, but again on the skin also some people will say that it causes burning on the skin. It will be having some effect. It's better than nothing.
Good afternoon. Am I audible?
Yes, please.
Hello. I generally use lubricant drops prior to it, or if it is irritation is more after that, after 2 to 3 minutes after installation. The patient gets quite good relief. And 2 to 3 minutes, when you put methyl cellulose or any lubricant, that will not wash out the effect of earlier one. Totally agree with you, sir.
My question is regarding the giant papillary conjunctivitis post-contact lens use. If you get a patient in a clinic setup, so I would like to know from the dais, how are you going to counsel this patient? Because these people are invariably wearing contact lenses for long periods of time. So obviously it is not going to settle down immediately post-treatment. And I have also encountered cases where they are so cosmetically aware of their looks, they are not willing to give up the contact lenses. So what are the options we can counsel them for, and how do we go about it?
I think the counseling regarding, you're asking that if you have a patient with giant papillary conjunctivitis secondary to the contact lens users, then how are you going to counsel them or not to use the contact lens in future? That's what you're asking?
Both the treatment and how long is the treatment going to continue?
Treatment is very stat. Whenever you have joint capillary secondary to any insult, you have to remove the insult first. So obviously you have to counsel not to use it, otherwise you will have the same issue. Then you have to treat it. Treatment will be like cipratarsal injections and along with other therapies. It works quite well there. Now regarding the I have seen one patient such. What we have done in that, like after the activity of the disease has settled, for what she was using contact lens, suppose she is using contact lens for myopia, then you give a definitive treatment for the myopia so that she doesn't use it. So you can counsel her to, do a definitive treatment for the myopia in form of the keratorefractive surgeries and all. But for doing keratorefractive surgery, her eye to be white. For making the eye white, we can give cipratarsal injections and other stuff which is available.
Yeah, so I think I would agree with Dr. Alok. These patients who are very conscious and they have been using contact lenses. So as with allergy and as with contact lens induced GPC, the most important task that we have at our hands is counseling to make them understand that this is what is causing their eye to worsen, and they would have this repeated episodes and they'll have to keep coming to the clinic. So asking them to stop contact lens becomes a very important aspect, and we have to really explain it to them and maybe click pictures. So what really helps me is that take pictures on the slit lamp, use slit lamp photography system, and show them once they come to you, show them what the picture is really like. And once you have treated for a while, once you have stopped contact lenses or you've given any cipratarsal steroids or whatever therapy you have started, show them the picture again and show them how it is improving their eye and their ocular health. So this, taking the photographs and showing them at different visits really helps in counseling. And once the eye is quiet, I would agree, I would offer them refractive surgery and ask them to stop wearing contact lenses.
The other thing you can try is that basically the GPC is an allergic phenomenon to contact lens, possibly deposits or proteins build-up, whatever is happening. You can try either daily disposable lens, or maybe you could try them to wear it for shorter periods when they're actually actively working and not use it for the rest of the time when they're just probably not actively working or they're in home or something like that. So something like that, modifications in their usage, either reducing time or replacing more frequently could also help. Many of these patients are actually, if you give 1 month lens, they use it till their eyes start becoming red, and then they get all these things. The problem is once it comes, it keeps coming again and again, so you need to probably counsel them not to overuse and discard lens as per schedule, or use faster discard time so that the lens build-up of whatever deposits might also go down.
Sometimes even I think the change of company can help. Different companies make different contact lens with different sheen, with different material and all that. So I think that can also be advisable. We can't afford the
once they start resuming their contact lens, once we see a regression in the GPC, what would be the protocol we would ask her to start wearing it? Will you say that we wear for 4 hours first, assess for 1 or 2 days, and then increase gradually every hour per day? Or what is it going to be like? If she has to.
You can't hear exactly. You are asking protocol of managing GPC?
No, sir. Just in case, if the GPC is completely regressed,
yes,
and the patient insists on continuing wearing the contact lenses,
yes,
which ideally should not be.
Correct.
So is there a protocol in there we will define the hours which she's supposed to start with, like 4 hours per day to start with, then slowly, gradually increase every 2-3 days and to assess? Or is there some thing in that?
I think maybe we'll have to check with the contact lens practitioner. Frankly, I am not in a position to answer that, but I think we need to look at reducing the wearage time, using some lubricant or antihistaminic drops can be given twice a day as a prophylaxis once the patient is better. But there may be a scientific protocol. I'm not aware. I'm not gone through the literature in that direction, but I think we can figure out, maybe talk to a specialist who do more lens work. Maybe they might Sir, I would like to know about the role of ketorolac, olopatadine, lipotestine, and alpastadine in these allergic disorders. Thank you.
So we are getting a lot of ketorolac-based preparations in combination and in isolation. One thing we need to understand is all NSAIDs are toxic to the corneal epithelium. So if you have a VKC patient which is already having epithelium unhealthy, then I definitely don't use a NSAID on those eyes. The typical indication to use a NSAID would be in a seasonal allergy or in an adult with mild itching and conjunctival signs. You can use a combination of antihistamine with a ketorolac combination. But if the cornea is showing any form of staining or there is a more severe form of allergy involving the cornea, I typically avoid using the ketorolac. They also have surface anesthetic properties which might be helping, but they may be deleterious with patients who have surface problems and corneal problems. So mild allergy, middle-aged patients or coming with just itching and not much of any corneal involvement, you can try to use ketorolac. If you have to compare lipotestine, alpastadine, olopatadine, so there are studies which show one is better than the other. I think the problem is it's very difficult to actually in practice be able to get a feedback that this is working better. So I think if you have a patient with mild allergy, you can give interchangeably, maybe give them olopatadine. After a few months, you can ask them to use lipotestine, and whichever they find better, they could continue. Theoretically, we have studies that the newer drug is better than the older drug. Practically, whether it works that way is difficult to exactly figure out in a small practice or in experience-wise. But you can interchange the drugs and see which patient is better comfortable with.
In addition to what doctor has said, I think we should look into the pathogenesis of all types of allergic conjunctivitis. Whenever all types of allergic conjunctivitis, they are both IgE mediated, except VKC and AKC, which are in addition to IgE mediated, there is a cellular response also. Now, if you look at all these allergies, they work by two pathways. One is lipoxidase pathway and cyclosporine pathway. So there is a formation of histamine mediators also, there is formation of prostaglandins and leukotrienes also. So if you look at NSAIDs, they act on only cyclooxidase pathway. They do not act on lipoxidase pathway. So the best way to offer to any person coming with allergy is to give the steroid, because they work on both the pathways if you really think so. So you have to understand that NSAIDs have a limitation. It can't take care of both the pathways by which an allergic response is happening.
So another molecule that works really well is the midazolam sodium or the mast cell stabilizer, but it has become increasingly difficult to get it. I've had in past and even now whenever it is available, keep the patients on this for a very long period of time along with tacrolimus eye ointment. So both of these, especially for VKC, work extremely well, although there have been issues with availability of the same.
I had a couple of questions. One is, what is the experience, if any, of 0.01 and 0.05 and 0.1 cyclosporine, which is typically used in dry eyes? That is one question. And the other is, how do you access acetylcysteine? Is there anything which is available of it?
So the commercial cyclosporine that we get is very useful if you have a very mild form of allergy. In the typical VKC patients, somehow you don't get adequate response. But once the VKC recovers, the child has grown out of VKC, has mild inflammation, you can try the commercial preparation. Acetylcysteine we get injection form, so that can be diluted to 10 or 20%. You get 20% injection and you can dilute it to 10% or use 20% as a mucolytic agent if you have a lot of, in whatever condition that you want to. Thanks.
So we would like to conclude this session. Thank you all for being here with us, and thank you for the wonderful interaction that we've had. Thank you to the audience, and thank you to all my co-instructors for
for being here with me today and conducting this session.